Welcome to the 5th season of Case Studies in Treating Ocular Surface Disease. This time, our esteemed panel of Drs. Justin Schweitzer, Jackie Garlich, and William Trattler deliberate on a myriad of interesting cases across the ocular surface spectrum. In our first case, Dr. Jackie Garlich discusses a patient presenting with complex meibomian gland dysfunction.
Hello, everyone. Thanks for joining us tonight. My name is Jackie Garlich, and I practice in Boston, Massachusetts. And I have the pleasure of sharing this talk with Dr. Justin Schweitzer and Dr. Bill Trattler. So Justin, I'll pass it to you and let you introduce yourself.
Yeah, just an honor and a pleasure to be here with the two of you. Excited about the conversation in regards to ocular surface disease and some MGD and a variety of other things. I practice at an ODMD practice in Sioux Falls, South Dakota called Vance Thompson Vision. I love what I get to do on a daily basis. So just an honor to be here with you guys and really looking forward to the discussion.
My name is Bill Trattler. I'm from Miami, Florida. I'm at the Center for Excellence in Eye Care. We're a mix of ophthalmologists, and we have one optometrist currently. And we have our goal is to have an integrated practice. And my specialty is cornea, especially cross-linking. I do a lot of dry eye, a lot of cataract surgery and refractive surgery, like LASIK and surface ablation. And just to share, I guess, my philosophy, we work really well with our both the optometrist in my practice, who's really a disease-focused optometrist and really involved in pre and post-operative management. So I feel very lucky to be in South Florida with just a great combination of both MDs and ODs working together to take care of patients.
That's great. I love to hear that collaboration. That is as it should be. So that's wonderful. Yes. Well, we all clearly have a love for ocular surface disease. I bought my practice 2 years ago and have a growing dry eye practice. So we are here today to talk about a few cases, and I'm going to start off this case with the title MGD with a Twist, which really makes me regret that I didn't think ahead and come up with a cocktail that we could have been drinking for this, as I feel like it's a name of a cocktail. It should be. Only like an eye doctor, I feel like, would appreciate that. So we'll begin here. So I have a 52-year-old white male patient who presented for complaints of dry eye that seems like it has gotten worse since I last saw him. And he was also complaining about some blurry vision, worse in the right eye than in the left eye. This did seem to fluctuate with his blinks. I did see him 4 months prior for his annual eye exam. And we had discussed at that time, dryness and a treatment plan for him to combat some of these symptoms. He didn't implement any of those things that we talked about previously. So he is back today and says, I feel like my dryness is getting worse. He is a contact lens wearer, so he does wear daily contact lenses 6-7 days a week. His medical history is positive for hypertension, and he controls that with amlodipine and hydrochlorothiazide. So here are his.
Can I ask? I'm so sorry. Can I ask a question? So why did your patient not start your therapy? He came in complaining of having a problem. You gave him a solution and he didn't even use it. I want to understand why.
I've got a little tidbit coming, for that reason. But thank you for pointing out that my patient was not compliant and adherent to my therapy.
Okay.
I did say when I had seen him 4 months prior, this was for a comprehensive exam, and he was, mostly there to update contacts, and, dryness was sort of like an aside. And I take meibography images on all of my patients, comprehensive or not. And so, I point these out to him and I say, hey, this, but my thought was he's been now more aware of these symptoms that we talked about at that exam 4 months ago. So this was kind of my thought process with this. So his exam findings, he is a little bit reduced vision-wise in the right eye. 20/25 does pinhole to 20/20s, 20/20 in the left eye. Speed score is 13. He does have significant meibomian gland dysfunction. It is worse in the right eye. His expressions are not amazing, turbid, toothpastey kind of expressions. And he does have some mild telangiectasias on his lash line. He does have a little bit of SPK, mostly nasal and temporal, and this is more apparent in his right eye than in his left eye. Tear breakup time significantly reduced, 3 seconds in the right, 5 seconds in the left. And meibography images are here. So you can see a noticeable amount of atrophy that's happening in this right eye. So seems like a pretty clear-cut plan. Okay, this is meibomian gland dysfunction. This all makes sense to me clinically. We talked about this 4 months ago. And when we talked about it 4 months ago, we said we should start an omega and do X, Y, and Z. So this is really a reiteration of what we kind of talked about the few months prior. So we started an omega-3 supplement. We did hypochlorous acid spray, and then we did thermal expression, which we performed that day. And we had spoken about that at the previous visit, so he was prepared for that. For the keratitis, I started loteprednol 4 times a day for a week, and then I had him discontinue contact lenses. So for all of my thermal expression patients, I always see them back in 1 month. And says he was better for about a week, but his symptoms have returned. And I look at him under slit lamp, and this is, better meibomian gland expression, does still have a little SPK, kind of like a patchy area temporally. And he has also this sort of disrupted epithelium. So it's not a abrasion, it's not an EBMD situation. It is almost like a waterlogged effect that you'll sometimes see in a scleral lens wearer. So normally, when I see my thermal expression patients back, they're very happy. It performs really well, and I get very good results with that. And so when this gentleman is saying not amazing, kind of better, but not really, my red flags go off. What did I miss in this patient?
First of all, it's a great case. I can't wait to see the final answer, but I'm just curious how you decide to use 1 week versus 2 weeks versus more in certain patients. For example, maybe, do you ever use it for 2 or 3 weeks or longer? Or how do you decide just a week here? For example, I'm just curious how you came up with a 1 week plan here.
Yeah, I do actually like using it for 2 weeks at a time. I do feel like I get better results when I do that, but this patient is kind of antsy to get back into contact lenses. But this is a good stopping point here, because I do want to open it up to the room and say, what do you think I maybe missed here? And what's something that I may have forgotten to look at?
Well, I initially looking at it, I don't think you missed anything. I think a couple questions I would have would be, you looked at the MG. I would love to know, was there any other type of blepharitis involved with this? The upper lids, how did they look? When we think about, anterior blepharitis. And then, I always run into the problem, and I'd love to know how you attack this, because I think Bill brought it up beautifully, is, you only use the steroid for a week, and you stated it was because of the contact lens. And I'm sure you see a ton of contact lens patients. And a lot of those patients have ocular surface disease. We know steroids, when there's corneal staining, are a great option for these patients. How do you get it long-term, and how do you use it long enough? And you can address that after we get done with our discussion. But I think the only other thing I'd want to know in this patient is, what did the upper lids look like? What did the patient, if they looked down, was there any type of blepharitis on the anterior surface of the lid or the lids and lashes?
Okay.
Perfect. Those are great questions.
Very good.
I'll say, I know about that patient that they talk about that have 20 contact lenses under their eyelids. So I'm afraid, he said it's a twist. I'm wondering, because you said there's still some irritation of the cornea and stuff like that. So I'm wondering if there's a secret stash of contact lenses that this patient forgot to tell you about.
Honestly, that would be a way better case if that is what it was. Okay. It is not, but Bill, you are correct. I did not flip this patient's lids when I first saw him. No, I did. Sorry, I did for his comprehensive exam. He has these concretions that have since are no longer embedded, and they are all exposed underneath this upper lid. And so the area of SPK that I'm seeing in this weirdo epithelium is all disrupted because these concretions are just kind of rubbing along this cornea. And this is why this poor gentleman is upset. But this was my reminder, you got to flip these lids to make sure there's nothing hiding under there. So we had these concretions removed. Then he was my wow patient for my thermal expression. This is what my normal thermal expression patients will say. So we had the concretions moved. His vision was back to normal. I did actually, which I didn't include in this slide, do a topography on him, and it was very much distorted by just having those concretions under there. His slit lamp exam looked good. His cornea was clear. And the plan here was really just to continue these omegas and warm compresses. So that is my words of wisdom for anyone that's watching this, is to not forget to actually evert those upper lids. There were not 20 contact lenses in there, but concretions are also pretty annoying for this patient. Okay. Thoughts on this case?
My only other thought around this was when you were presenting and you talked about that area that was kind of looked like SPK, loose epithelium. You mentioned it. I was thinking, well, could there be some underlying EBMD here? Is there a, early Salzman's nodular degeneration that's leading to that epithelium being beat up? And we need to address that. But typically, if you treat the ocular surface, it's going to get better. I am terrible at remembering to flip the lids. So I'll be honest with you, like having this case in front of me is eye-opening, because a lot of times I don't think about it unless it's someone that comes in for a foreign body, and then I'm obviously going to do that, but I don't think about it in my dry eye patients or my MGD patients ever.
Yeah. Okay. Well, good. Then I don't feel as bad that I missed that.
Yes. Perfect. Well, I was going to ask you, so, I mean, it is a spectacular case. And just now that we solved the case, I guess my question is a long-term plan. I mean, this patient already has a lot of meibomian gland loss. And I think omega-3s are helpful and warm compresses, but I'm a pretty big fan of continuing the hypochlorous acid spray twice a day. I just think that there's a bacteria component to this. And I'm just curious that if you typically do that. I mean, it's inexpensive, it's easy to do, takes a second or two per patient. I'm not sure if is that a typical part of your treatment plan for these patients, or not always?
Yeah, no, it absolutely is. I'm realizing I left it out of this plan here. It was continuing all of that same therapy minus the steroid. I love hypochlorous spray. I feel like that is extremely helpful in really dampening down that bacterial burden on the lash line. So I do very much like that. And for this particular patient, and for a lot of my patients, a lot of the conversation on what our actual treatment plan is going to be is really a conversation between both of us. And so, you could make a case for starting some other therapy at this point, but he was doing well and feeling good. And now that we have actually made some steps and some improvements, I feel fine with this continuing that treatment plan. And then, following up in 3 months, 6 months, I forget when I'm seeing him again, actually, but and just kind of monitoring and then, deciding further treatments as needed. But I agree with you, Bill. I absolutely continue the hypochlorous spray.
Perfect.
I also just want to comment, this is a great case to remind some of the listeners, that you have, in my mind, the 4 big pieces that you need if you want to really start managing ocular surface disease or MGD. It's nice to have all this beautiful technology, and those images you have were amazing. And I love my biography as well, but you had the questionnaire in here, you use the speed questionnaire. I think that's a key piece to this case. I think you need a slit lamp, which we all have, every optometrist, ophthalmologist has a slit lamp. Vital dyes, you stained. So you're going to be able to look at the cornea, you're going to be able to look at the conjunctiva, and then you need a thumb or an index finger to assess the meibum to be able to look at that. And if you have those 4 pieces, you can actually start really treat. It's a really good reminder that at times when we feel a little overwhelmed, if we should really start managing patients, how we should manage them, that those 4 pieces that you showed in this particular case is a really good starting point to be able to manage these types of patients.
Thank you for joining to listen to the MGD with a Twist.
In this next session, Dr. Justin Schweitzer showcases a diabetic patient with decreased corneal sensitivity.
Hi, my name is Justin Schweitzer. I'm an optometrist at Vance Thompson Vision, and really excited to be able to share this case with really 2 great colleagues and masterminds in ocular surface disease and dry eye. And so this particular patient was an 82-year-old male Caucasian that presented to my clinic and had stated, his vision had been declining over time. And I'd seen this patient in the past a few times, and I was working alongside a colleague in the community that was managing him as well, managing his glaucoma. And he really wasn't sure why his vision was declining. And he came in, he said, I'm not in any pain. I'm not having any discomfort, but I just don't see like I used to see. I'm not seeing well. And you can obviously see by his vision here when we drop down a little bit that he's not seeing well. 22/50 in his right eye and 20/50 in his left eye. And this was best corrected. Really couldn't improve his vision much more than that. His intraocular pressure was actually fairly well and very well controlled for him, with his Kmax or his Tmax pressure being in the upper 20s. So his glaucoma was very well under control at this point in time. But when you look at his history, and these all come into play, and it's very important in this particular case, his personal medical history, he is diabetic. He's had multiple surgeries, cataract extraction, as well as a blepharoplasty. He's been on a prostaglandin analog for an extended period of time, north of 20 years at this point in time when I saw him, and he has been being treated. And so the optometrist that I was working with in the community had tried a variety of different things. They'd tried some topical corticosteroid. They had plugged this patient with some punctal plugs, had done some immunomodulators twice a day, some preservative-free artificial tears, and really nothing seemed to be helping. And you can see the slit lamp exam when I stained his cornea, and you could see there's diffuse SPK, diffuse punctate epithelial erosion, across really the whole cornea. His fundus exam was very normal, besides the glaucoma piece of thing, but there was no issues with the macula or anything along those pieces. And so I'm going to pause there and just want to open up the discussion here to the group and to Bill and Jackie. What are some other considerations that you would want to take into account in a patient like this that presents like this with a healthy retina, with glaucoma, but well controlled and not progressing, but obviously having declined vision and a corneal presentation like that?
So this is a case where I would definitely be testing a corneal sensitivity on this patient. So this is, I feel like, a very classic, no pain, but lots of staining on the cornea. And I'd be very suspicious of a neurotrophic keratitis in this case. So I in my clinic use the old dental floss to test corneal sensitivity. So that's probably something else I'd want to see what's going on there, but also lids. I'm not sure if you commented on the lids of this patient.
That's a great question. I did not comment on the lids of this particular patient, and I don't have it listed here, but he definitely has some MGD. He definitely has some mild blepharitis as well. That was being fairly well managed again by, the primary optometrist that I was working alongside of, because he'd been hitting it with topical corticosteroids and doing some other treatments as well. Bill, anything to add to what Jackie said at all?
No, I mean, I think obviously she's going down a particular pathway, which you've kind of led us down as well. And I think that these patients that are on these chronic glaucoma medications, their surface just gets beat up. I mean, that's the big problem. And so I'm always trying to figure out, is there a way we can treat this glaucoma without a way to stop the topical medications, since they've been using it for 20 years, and maybe, there's going to be a laser treatment or some other treatment that can be done, Durista or something, to get the patient off of a topical glaucoma medication. That may be very important to try to rehabilitate this cornea.
No, that's such an important point when we think about treating these types of patients. How do you minimize the medication burden? So I'm glad you brought that up, because we do have glaucoma drug delivery. We do have BAK-free drugs. We do have preservative-free drugs we can consider, SLT, of course. So I'm really glad you brought that up. And with this particular patient, that was on my mind. And I did do, corneal sensitivity testing with this particular patient. And it is a critical question to ask, when you see that much staining, if the patient has any pain. And he was in no pain. And with that much staining, I would expect there to be some type of pain. And Jackie, you mentioned you use dental floss. Myself, I actually use a cotton wisp when I do it. Bill, how do you test corneal sensitivity? I got to ask.
Well, I have to be honest. I mean, why do you need to test corneal sensitivity? You know the answer already. I mean, what if it comes out that the patient feels that wisp? It says, yes, I feel it. I mean, is that going to change how you're going to manage this patient? I mean, other than, obviously the one FDA approved medication for true neurotrophic keratitis, I mean, it's really not going to change your management at this point. So it's going to be exactly the same, to be honest. I mean, I usually use a cotton tip and I just use the wisp, but I honestly just go ahead and start treating, because my treatment's not really changing based on this outcome.
No, I don't disagree with you at all. I think the main reason I did is because based on his history, I was already going down the path knowing exactly what you said, is even without corneal sensitivity, I was pretty sure this was going to be an NK case. But we do know with the one FDA approved medication out there that the one thing they require in the chart note is you got to test corneal sensitivity. That's the only reason. But I agree with you. You probably didn't need it, except that he'd been on so many different things, the cyclosporin, the topical corticosteroids, that I thought, well, I have some other considerations, but I may be going down a path to use an FDA approved medication, which we'll touch on here in a second. And so I did do corneal sensitivity testing very quickly in this particular patient. He was completely anesthesia, so he did not feel anything. And when I do corneal sensitivity testing, I usually test, superior temporal, superior nasal, inferior temporal, inferior nasal, central. In this patient, you really need to do that. He wasn't feeling anything on his corneas at all, no matter where you rubbed the cotton swab at. He wasn't going to be able to feel that. And so that led me to the diagnosis, which I diagnosed him as stage 1 neurotrophic keratitis in this particular situation. And really, just to review these really quickly before we get into discussion around this, there's really 3 stages based on neurotrophic keratitis, or the Mackey classification. This patient fell in stage 1 because of the fact that he had, some punctate epithelial erosions, or SPK. He didn't really have any corneal edema or neovascularization or stromal scarring, but he fell in stage 1. Stage 2 is that persistent epithelial defect which he did not have, but that would be stage 2. And then stage 3 would be stromal involvement and actually stromal melting or an ulcer that's present as well. So it's just a review of our levels of neurotrophic keratitis, and he fell right into stage 1. And so now getting into the fun part with you guys, what about treatments considerations? The options that were attempted were topical corticosteroids, punctal plugs, immunomodulators, preservative-free artificial tears. And then I had to think about, well, what would I do next? And I listed the other considerations, but I would love to hear your guys' thoughts. And I'll specifically ask, Jackie, right off the bat, I'll just ask you and say, is your next step when you see a patient that's been all of this on a stage 1 NK situation, do you attempt any of the other considerations that I talked about, or am I missing something?
No, I do have a question. Does this patient still have punctal plugs there? Because that is something that I don't use a lot of punctal plugs, because especially if this patient has a lot of meibomian gland disease and that isn't really cleaned up well, although maybe you did say that the primary optometrist was managing that well. I would just make sure that we're not trapping whatever inflammatory mediators on the eye with the punctal plugs. But this is a great case, I think, for an amniotic membrane for this patient. So I certainly wouldn't hesitate to use an amniotic membrane in this case.
Yeah, great point on the inflammation. The patient did have punctal plugs, and the primary care optometrist that I was working with was treating with the topical corticosteroid, calming down that inflammation. But I am a big believer that I don't plug when there's inflammation on there. So I think that's a great point. There was punctal plugs still present in this particular patient. Bill, I know you were going to comment, and I kind of jumped in. Go ahead. I'm sorry.
No, it's perfect. Well, okay. So just to share, so I'm in Miami, Florida, and Schaefer Sang, who developed Procera, we work at the same surgery center. So I've had a chance to work with him for 20 years. We're not in the same practice, but I've had a chance to consult with him on many, many patients. And so you guys are right. This patient needs punctal plugs, even in the presence of inflammation, because you're going to treat the inflammation with an anti-inflammatory. But you need to raise the tear volume as much as possible. So he recommends, and what I do is both lower and upper plugs, which is most people don't do. Most people will just do the lower plugs, forget about they don't even consider the upper plugs. But if you put the upper plugs in, the volume's going to go way up, and you're going to do a much better job. And then when you get to Procera, it's going to actually work much better. So it'll dissolve a little less quickly. And so that's always Dr. Sang's recommendation for Procera is you do upper and lower plugs. You can you don't necessarily need a steroid if you're using Procera. But if you're not using Procera, you could use a steroid to try to reduce the inflammation. So just throwing that out there as a comment.
Oh, it's a great comment. I love, I love the artfulness around all of this too. We have all these different comments. There's no necessarily perfect way to do it. There's none of us have a monopoly on the truth, but we have different ways of approaching it. And just hearing you two talk about it is great. And so I do agree. I think an amniotic membrane graft was a consideration here. I thought about autologous serum drops as well in this particular situation, or a biologic. Do we do that for this particular patient? I don't love a Tosarfi just because I don't love closing the eyelid. I mean, you could do partial, but gosh, this gentleman, I didn't want him I wanted him to still be able to live life. I didn't want to close that at this point in time. And so the first 3 were really the 3 that I was kind of debating or discussing on what I would do. And ultimately, what I did is I did go with Sinidramine, the BKBJ 20 mcg per milliliter. And, this is a FDA approved medication that is for stage 1, 2, or 3 neurotrophic keratitis. And I don't typically in stage 1 go right to that, to be completely honest. And I'd love to hear your guys' thoughts on that. I do attempt a lot of things that were already attempted in a patient like this, where I'll treat the inflammation, I'll use some immunomodulators, I'll make sure the meibomian glands are functioning. I will plug, and I will consider the biologics or autologous serum before I jump to that. But in this particular case, why I felt like I needed to go to it was just because of all the things that he'd been through, and then where his visual acuity was as well at 2250. And so that's what I did, and dosed it 6 times a day for 8 weeks. And at 8 weeks, we saw a really nice improvement. He went from 2250 to 2040. You can see that, his cornea cleared up. It wasn't 100%. And this is someone that we're still managing and going to have to continue to manage because we got a chronic issue that we're dealing with. But we definitely improved his life with this particular medication in this particular situation. So, Bill, I'm going to throw the question to you now. Do you agree that you would try some of those other options first before you jump right away to this particular medication? Or do you how do you stratify, or when do you decide to use something like this? Because I'm sure a lot of our listeners want to know that and are interested in that.
Well, first of all, congratulations. I mean, this set of improvement, this patient is loving you. I mean, any regimen I'm about to tell you is going to take much longer than this period of time to get to 2040, just to throw that out there. So this was a quick improvement for this patient. One thing that I always try to figure out is there a way to, we talked about it a few minutes ago, can we stop the prostaglandin? Because maybe that's one of the primary issues. And in the FDA clinical trials, for this drug, they had to get off all the topical medications before they could be enrolled in the study. And so I wonder if that may have played a role, but did you stop it or you continued it and were able to use this medication?
I did continue it because of his
Nice.
glaucoma. In this
Right.
situation, I still love your thought on reducing medication burden. It's on my mind all the time. So I think it's just a brilliant thought in this particular case that I didn't really consider because I didn't want his pressure to get out of control. But I think for short-term use, it would have been a smart thing to do. And we can always get him back on it later.
Right. So one thing that's interesting is if we wanted to enroll this patient in an FDA clinical trial for a glaucoma medication, we would make them wash out of the prostaglandin for about a month. And that's what every clinical trial does. So if they're going to wash out, if the FDA says it's okay to get this patient off of medication for about a month, why can't we just do it here for a month? And then he's well controlled, as you mentioned, just stop it for a month and then restart after he's turned the corner. It's just throwing out one other thought or concept. I know it's hard to do. It's like this pressure is going to be high, but maybe it's the right thing to do in this one situation because this is affecting his vision far more than the glaucoma is right now.
Agree 100%.
Can I ask what would be your hesitation in starting oxybate sooner? You were saying, oh, I would maybe try X, Y, and Z first. Is there a reason you would say, oh, I'll wait to try these things first as opposed to just jumping into an oxybate?
Yeah, I don't have a lot of hesitation. I've used the medication quite often, have had extremely great luck with it. I think part of the reason is his age. Part of it was, his nervousness around the fact that he was going to have to take a medication 6 times a day for 8 weeks. And I do take that into account. And I do talk to my patients about that. And I never mentioned that at the beginning of the case. And he'd been through a lot. He'd been on a lot of different treatment options that weren't working. And so this was someone that was fairly frustrated in general with how he was seeing and what was happening in his life. And so I have no problem jumping in earlier with it. I think it fit with this one, but I do take into account a little bit about what the patient's lifestyle is and do I think they can be compliant with taking something 6 times a day for 8 weeks.
That's a good point. Now, sometimes it takes a couple of weeks to actually get the medication to the patient. So you could be doing a couple of things in advance. And then by the time they get the medication, they're already just a little bit better. And this drug can even work more easily and help even more.
This is a great case. This is amazing.
Well, I sure appreciate your guys' time on this and all the discussion and the considerations around it. I'm going to sign off and I hope everyone can join us for another case very, very soon.
In this final case, Dr. William Trattler discusses a severe case of dry eye disease prior to cataract surgery.
So hi, I'm Bill Trattler from Miami, Florida. I'm here with 2 outstanding, interior segment specialists and we're talking about dry eye. We have Justin Schweitzer and Jackie Garlich. So you're both amazing experts in ocular surface disease, dry eye, and we're going to have a fun, interesting case, which I love to get your thoughts on. And my title is The Impact of Dry Eye and MGD on Cataract Surgery Planning. And this is our patient. So it's an 80-year-old female who comes in for cataract surgery consultation, just like all the patients you see in your practices. The patient reports some reduced vision. Their vision is 20/50 in one eye, 20/60 in the other. And you do this little exam, they have cataract, so pretty consistent with the 20/50, 20/60 vision. We do know that they have a low tear film level. And Dr. Garlick, for you, for patients presenting for cataract surgery, do you notice that when you have patients coming in you see patients that have cataracts, they're visually significant, they probably need cataract surgery. Do you notice that they commonly complain of foreign body sensation when they have dry eye? And do they usually have complaints of dry eye, or are they usually more asymptomatic?
No, I do feel like they complain more about dry eye. I mean, certainly we know dry eye is more prevalent as we age. So it would make sense that we do see that more in our cataract surgery patients. And I do experience that as well. I do feel like they complain a bit more. Not always. This is not always a given, but it certainly is, something that we hear and something we have to look out for when we're referring for cataract surgery.
Absolutely. That's a great point. We definitely see patients that have complaints of dry eye. But what's interesting is we did this study where we actually surveyed patients who are coming for cataract surgery at multiple sites around the US. and we asked them whether they had symptoms of dry eye. And it was interesting that the patients coming in for cataract surgery, most of them actually were saying at the time, again, this is just their symptoms of dry eye, a foreign body sensation. Most of them had no symptoms at all. They had no foreign body sensation, and 28% said maybe some of the time I have a little dry eye, foreign body sensation, but nothing too exciting. So it's really 87% of our patients said that they had minimal to no symptoms coming in for cataract surgery consultation. And these were patients actually that had cataracts who were already scheduled for cataract surgery. So there's only 13% of patients that were actually very symptomatic. So if you look at a big population of patients coming in for cataract surgery, most actually don't complain a lot about dry eye. They're not going to tell the three of us, hey, I have dry eyes. They're going to come in saying, I can't see, as their main complaint. So the patient comes in, we do the initial biometry, we do the OCT, the macula, and topography, which I do on every patient. I find it's very helpful. And so now this is for Dr. Schweitzer. So how common do you think dry eye is in our patients coming in for cataract surgery? Do we see it in about 10% of our patients, 20% of our patients? How common is dry eye overall?
Very, very common. I would say it's well north of 50%. I mean, I think of today, I did 8 cataract evaluations in prep, and 6 out of the 8 had at least some level of dry eye that we needed to manage and take care of. So, I'd say 70 to 75% of our patients that come in that are wanting cataract surgery have some type of dry component, different levels, but different, but types of dry eye.
Right. See, the challenge of these questions is you guys are both fantastic experts. You guys know, you're both very knowledgeable. So I agree. I think it's a very high percent. And so again, in that study, we looked at some of the numbers. So again, we found that even though the patients were asymptomatic, I showed you such a high percent they were asymptomatic, we found the tear breakup time was abnormal, actually very abnormal. It was 60% of our patients had a tear breakup time of less than 5 seconds in the study, a multi-center study. And 50% had central corneal staining, 76% had any form of corneal staining, and our Schirmer's test, which I don't normally do in my practice, but it was part of the study, was actually extremely low in about 21% of patients. So it's actually matching up, Justin, with what you just saw in your last day of seeing patients. Jackie, do you agree? Is that kind of what you see in your patients who have cataracts? What's your experience?
Yeah, I think actually a point on the previous slide is that I think a lot of times, and I don't know what the questions are in this study for the first slide, but I think a lot of it is how and in what way you're asking the questions about whether or not someone has dry eye, because dry eye is associated with a lot of symptoms, but fluctuating vision is one of them. And if you're really trying to tease out what this cataract patient is suffering from, fluctuating vision is certainly one of them. But to answer your question here, I do certainly, I think we're all very much looking for dry eye in all of our patients. So it's very easy for us to, I think, find that in a lot of patients, but it certainly is very prevalent in this population.
Right. So here's our topography and our IOL master. And who wants to jump in and share what your thoughts are on this patient's findings so far?
Yeah, I can jump in. Just looking at the topo right there, I'm already a little concerned. It looks a bit irregular. I never like to see the colors kind of changing like that. So there's a little bit of irregularity there that's going to raise a little bit of a red flag for me right off the bat. Yeah,
it absolutely is. There's a good amount of meibomian gland atrophy, and mostly centrally here, but you can still see that in particular in this left eye, nasally, more so on the left eye than the right eye. But there's a good amount of meibomian gland atrophy. I'd be very curious what that expression looks like on that patient.
Absolutely. That's a great point. And perfect. And so this is a question I'm going to ask you, Jackie, so ignore the Dr. Schweitzer there. Is there a way that we can make this better? Like, can you actually regrow these glands, or do you think once they're gone, and we just have to try to maximize the health of what's left?
So I tell patients when I'm talking about this with them, once these glands are gone, they're gone. But in reality, there are case reports of showing a few millimeters of growth using different therapies. So particularly IPL. So I know Laura Perryman does a lot of this work in her clinic, and she's published a few case reports on this. But I tell also patients, like, this isn't really widely accepted just yet. We don't really have anything that can actually regrow these glands. So once they are gone, there's not much I can do for those. So let's work on preserving and improving what we've got. Okay, perfect. Thank you. I'm in agreement with you. These are tough. So the entire patient started off with, and you can see that's how they're looking on the side. And this is my plan. So
as we talked about, all three of us love hypochlorous acid spray, which helps reduce the bacterial load in the eyelids and hopefully get less lipase secretion, so less MGD down the road. We also started this patient on topical steroids to reduce the inflammation, some warm compresses with some little expression to help improve the meibomian gland secretions. And any other recommendations? These are just a couple of things that can be done. What else do you guys like to do in this type of scenario?
For me, I love where you started here. I like to keep it fairly simple at the beginning, so I'm not going to add a lot for another recommendation. Now, I'm always trying to think ahead. So I love where you started here. I love to reduce inflammation. I love we're going to treat the glands. I love the hypochlorous acid. And then if the patient comes back in a month or so, I may consider adding, an immunomodulator of some point. I may consider plugging the patient as well because I feel like I've got the inflammation down. But I love where you're starting here with this, Bill.
Yeah, I agree also. I think in terms of the warming therapies, there was actually a study that I don't believe was funded by LipiFlow, but I don't know if either of you have seen this, but there was a study that showed doing LipiFlow prior to cataract surgery really improved cataract surgery outcomes. And so I think warming therapies in terms of a warm compress are good, but better is more of an in-office thermal expression. So I think that's certainly something that we could add to the list, but I agree with what you've got here. It's a good starting point. Omega-3s would be another option, but these are obviously not acute. They don't work fast. So down the road, perhaps.
Beautiful. Well, thanks you guys. So now this is how the patient looks. So this is we did with the hypochlorous acid spray, worked on the lids, and then also topical steroids. And you can see the nice improvement in this topography. And also we look at the keratometry readings. You can see they're lining up much better. The Ks are much more symmetrical. So now we're getting a much better reading. So you can see just by treating this patient, we're gonna get a much better outcome when we actually perform cataract surgery. Of course, what's also interesting is that, and I'm sure you guys have seen this as well, patients are often asymptomatic prior to cataract surgery. They undergo cataract surgery, which is a surgical procedure, plus they're on these drops for a month. And I find about 6 weeks later, they're often more symptomatic. They have more foreign body sensation. They say, what's wrong now? Like they're more sensitive. So if we don't treat them ahead of time, then they get upset at us afterwards. And I have to remind them, look, we already treated you ahead of time. We identified this. It's just, it's still your dry eye just acting up. But great points, Jackie. Obviously, there's different various other options that we could have used for treatment. Justin, you came up with some good ideas. Jackie, great ideas as well. So in my practice, like now that the scans look better, I actually would go ahead and schedule the patient for cataract surgery. I think that I feel comfortable with how that particular patient looks. I'll share that I did my mom's cataract surgery, and it took me months to try to improve her ocular surface disease. Even though my dad's been treating her with Restasis and some other therapies, when I got a chance to see her before cataract surgery, she had terrible MGD. It was just very frustrating. We did LipiFlow, lots of therapy, Regenerize, steroids, and I eventually had to go with a light adjustable lens because I didn't trust my K readings. And actually, thank God I was correct because I was still a diopter off, more hyperopic than expected, but I got to adjust her back to 20/20 with a light adjustable lens. So
oh my gosh, it's always family. It's always family that would happen.
Exactly. But also it was great because we've had a chance to learn. I mean, think about where we were 10 years ago, and my mom gets the benefit of what all three of us have learned over the last 10 years on treating MGD, how to manage patients, the importance of evaluating patients and treating them ahead of time. It wasn't done as commonly 10 years ago. So she benefited from everything that three of us have learned, and from us and all our colleagues. So I think we're all very lucky. So beautiful. So you guys are just two fantastic experts in ocular surface disease and dry eye, and so it's really fun, being with you, Justin, and with you, Jackie, and being able to discuss this case. And I'm looking forward to future cases that we can all share together. Thank you.
Thank you to our panel for an engaging and informative discussion, and thank you for listening.